Hi everyone. We are so elated to meet you in the program of Ward Rounds. Shall we discuss the case, sir?
Yeah, thank you.
Okay, sir. A 50-year-old male patient, known case of type 2 diabetes.
Okay.
So, presented with a high-grade fever with chills and rigors and a breathing difficulty. He was found to have BP 80/60, sir.
Okay.
Okay. So, how will you manage this patient, sir?
So this patient presented with breathing difficulty.
Yes,
Okay,
sir.
fine. So any patient who presents with breathing difficulty and fever, you will have many differential diagnoses. Okay.
Yes.
So the first most important is it may be a simple fever-induced tachypnea. Okay. First you have to think that one. Okay. Then once fever gets settled down with IV paracetamol, then you just check out the respiratory rate. Okay. Still respiratory rate is very high. Okay. So any patient who presents with the fever, with the tachypnea, even after settling the fever, still if you observe patient is found to have tachypnea, then probably you have to think of sepsis. So can you say any kind of biomarker which can helpful in delineating the sepsis?
Yes, sir. Yes, sir. So, his PCT, procalcitonin.
Oh, did you check
yes, sir.
procalcitonin?
Yes, sir, we have
Yeah.
checked.
Okay.
His procalcitonin is around something 28.
Okay, so procalcitonin would be very useful because the elevation of procalcitonin definitely can signal the presence of sepsis. So any patient who has had sepsis, what you have to do, better to draw blood culture first.
Okay.
Very, very important. So many times what I have witnessed, so people is getting antibiotic very hastily, but we often fail to draw blood for culture. That's very, very important because blood culture will show the organism. So this patient presented with fever, chills and rigor. So any patient who presents with chills and rigor, probably many differential diagnoses you can draw. The first most important UTI, urinary tract. This patient male or female?
Male, sir. Male patient.
Okay. So anybody who presents with fever and chills and rigor, definitely you have to think of urinary tract infection. I think that preferably I could foresee the presence of pyelonephritis. And second one, pneumonia. So pneumonia. So what about auscultatory finding in this patient?
Yes, sir. His lung signs are absolutely normal.
Okay.
Yes.
Suppose if patient has cryptations one particular area, for example, right infrascapular area, then probably you can think of right lower lobe consolidation. So right lower lobe consolidation can produce fever and breathing difficulty even without producing sepsis. So, but the most important clinching point, what I am trying to insist, even in the absence of cryptation, so according to your statement, lungs are very normal. Am I right? So lungs are very normal. In the absence of lung signs, patient still has dyspnea even after settling of fever, then probably definitely you can think of sepsis. The most important strengthening point would be the presence of elevated procalcitonin. So definitely you have to think of sepsis, but only one thing is you have to draw blood culture. That's very, very important.
Okay,
so blood culture, I think that sometimes I personally feel blood culture should be done in very reputed lab. So sometimes blood cultures, there are so many blood culture reports turned out to be negative blood culture.
Okay.
So I recommend it has to be subjected to in a very reputed lab. That's very, very important. Blood culture. That's another point. Then patient has breathing difficulty, you are telling. And now we are thinking in terms of sepsis. Am I right?
Yes.
So the most important is now you are able to think of sepsis. Then the consequence of sepsis also you have to think of. So patient has hypotension. Is there any evidence of acute kidney injury? Because what about urea creatinine?
Yes, sir. His urea creatinine is elevated.
How much blood urea?
Urea is around 160.
Oh, 160.
Yes,
Creatinine?
sir. Creatinine 2.8, sir.
How many years of old diabetic?
Around 10 years, sir.
Oh, 10 years. So 10 years of old diabetic, probably we are not very sure. It is an acute kidney injury induced by the sepsis, or maybe I think that without his knowledge, probably he may be harboring chronic kidney disease also. It may be a sign of acute kidney injury on top of chronic kidney disease. That can be easily differentiated by, I think that by doing ultrasound. If you do ultrasound, if ultrasound shows very normal kidneys, so in the presence of normal kidneys, sonologically, Then if you have elevated urea creatinine, then you have to think of a new onset of
Okay,
acute
sir.
kidney injury.
So
Suppose any background of CKD, then probably you have to think of
in this patient, ultrasound features suggestive of pyelonephritis.
pyelonephritis.
Yes.
Not, I think that no evidence of CKD.
No,
So
sir.
our initial differential diagnosis for fever and chills and rigor, as I told you earlier, one is pyelonephritis that really turned out to be pyelonephritis.
Pyelonephritis.
But even pneumonia, then malaria. So,
Yes.
so in India, you should not forget that malaria, fever, chills and rigor. Then sometimes leptospirosis, rickettsia, they can produce chills and rigor.
Okay.
Even acute sinusitis we have seen. Anywhere abscess, okay, abscess in our body can produce chills and rigor. Very rarely I have seen tuberculosis. See, suppose somebody presents with 1 month of fever, chills and rigor. So chills and rigor, generally we won't think of tuberculosis at very first place. But a long-term history with chills and rigor and the fever, even tuberculosis can present something like that. Even lymphoma, they can present with fever and chills and rigor. So these are the possibilities. But generally, any long-term diabetic, very easily you can think of pyelonephritis. So did you check loin tenderness? You didn't check.
No, sir.
Oh, okay. So suppose if you suspect pyelonephritis, check of loin tenderness. Okay, in the loin, if you press, then definitely you can elicit the tenderness. So these, what about the urine routine finding basically? So in urine routine, what you have to look for? Puzzles, because most of the time people always will be trying to find out signs of sepsis, but small issues you have to look for. Okay, so even your what I could say, that a simple urine routine examination may throw clues, like including pus cells and bacteria present. Okay, then what I could say, leukocytes presence. These are the findings suggestive of infection. What about the finding of complete blood count?
So total count is 28,000,
Oh,
sir.
28,000.
Yes,
So
sir.
definitely
His
the strengthens
hemoglobin
our
is
finding.
very low. It's
How much hemoglobin?
8.1.
So male patient hemoglobin 8, I think that's very concerned one.
Yes.
But I think that now WBC is around 28,000.
Yes.
So I think that it's heading towards infection. There's no doubt about that. You have
Platelet
told
is also reduced, the 1,30,000.
38. So it's all points out, okay, sepsis. So the commonest findings of sepsis in complete blood count is, one is leukocytosis. But sepsis, generally you will have leukocytosis, even normal WBC count, even leukopenia also. But generally what we witness is leukocytosis. Okay. Then thrombocytopenia definitely strengthens. So thrombocytopenia is one of the inseparable findings of sepsis. So definitely it signals. Of course, you told very clearly there is elevation of procalcitonin. And one more thing I would like to remind. Okay, the most earliest symptoms of sepsis is tachypnea. Okay, so any patient who has been admitted for fever, okay, after settling of fever, if you have the evidence of tachypnea, respiratory rate, what about respiratory rate in this patient?
Yes, respiratory rate is increased.
How much?
Around 38, 40.
Oh, 38 and 40.
this range.
So any patient who has been admitted for fever, in the absence of fever, when they have tachypnea, you have to think of sepsis. And especially in the absence of lung signs, then probably you have to find out some source outside of the lung. I mean, here it turns out to be pyelonephritis. You just look at the WBC. Now WBC leukocytosis, and you have thrombocytopenia, very important finding, and you have acute kidney injury. So patient has, and hypotension, that's very important. Then more important is septic coagulopathy also, you can't forget about it. Okay, that's very important, coagulopathy. So you have to check PT, INR and APTT. That's also very important. So this patient has BP 80/60. So management, the first most important, you have to give fluid resuscitation. That's very important. So which fluid you prefer?
Absolutely normal saline.
Normal saline. So why you prefer normal saline over other fluid? Ask you, what is the reason for not 5% dextrose?
Okay, so 5% dextrose is nothing but plain water.
Yeah, true.
So normal saline, the osmolality of normal saline is equal to our serum osmolality.
So that's very good, well taken point.
Okay,
so you have to choose an IV fluid which is synonymous with your serum osmolality. So serum osmolality, you have chosen 0.9% normal saline wisely, because 5%, if you infuse 5% dextrose, only, see, if you infuse 1 liter 5% dextrose, only 80 ml will stay back in the intravascular compartment. That's very, very important.
Yes.
So we may think otherwise. So when you infuse 1 liter 5% dextrose, so the entire 1 liter will get into intravascular compartment, so it will elevate blood pressure. No. If you infuse 1 liter 5% dextrose, only 80 ml will stay back. So it won't elevate your blood pressure. That's very, very important. And second one, during the time of sepsis, there will be peripheral hypoxia. So the tissues are, they are dealing with hypoxia. So what happens when you infuse 5% dose, this dextrose will be converted into what? In the presence of hypoxia? Lactic acid. So what happened? Already in sepsis, there is acute kidney injury. They will have some form of metabolic acidosis.
Okay.
This when you give 5% dextrose, this 5% dextrose is converted into lactic acidosis in the presence of hypoxia. Okay, at the periphery. So lactic acidosis will further, worsen the metabolic acidosis. But the most important is the consequence of metabolic acidosis is hypotension.
Okay.
So if you infuse 5% dextrose, by inducing lactic acidosis, again it worsens the hypotension. That's very, very important. That's why we won't prefer. Then apart from that, if you infuse 5% dextrose rapidly, because of osmotic diuresis, again 5% dextrose will be wasted in the urine. That's another, all the water will be excreted in the urine. Okay. So they say that if you infuse 5% dextrose more than 700 ml within an hour, then everything will go as an urine by means of osmotic diuresis. That's very, very important. So 5% dextrose, I think that's generally is contraindicated. And ringer lactate also, because it contains sodium is only 130 milliequivalent. Our plasma sodium is around 145 milliequivalent. So it is also may not be useful. So as you told earlier, normosaline would be the ideal choice. So this patient, you have to elevate the blood pressure with normosaline. So you can infuse 2 liter normosaline. That's very, very important. So they say any patient who presents with sepsis, so 30 ml per kg. So most of the patient's weight is around 60 kg. So 60 into 30 somewhere around 1800 ml. So you can infuse 2 liter of normosaline, okay, in a go. So despite giving 2 liter of normosaline, still patient BP is not able to be elevated, then you have to introduce inotropes like noradrenaline and so on, this patient. What about this patient, ABG? Did you do ABG?
Yes, sir.
Okay.
ABG.
What are the
ABG,
findings?
Sir, pH is 7.21.
Okay. What about bicarbonate?
Bicarbonate is 14.
Oh, 14. So
Yes,
that means a normal value of bicarbonate is around 20.
20.
So 14 means the patient is in metabolic acidosis. So this patient has metabolic acidosis due to various reasons.
Yes.
And I would like to ask one question. What about blood sugar level?
Blood sugar level is very high, around 550 milligram per
What about
kg,
urine ketone?
Urine ketone 3 plus.
3 plus.
Yes.
So I think that this patient has metabolic acidosis due to various reasons. One is diabetic ketoacidosis. Patient has suffered acute kidney injury. Acute kidney injury can produce acidosis. Probably this patient doesn't have hypoxia according to your statement.
Yes.
So hypoxia can induce lactic acidosis, by which you will have metabolic acidosis. So these are the few causes of acidosis. So this patient has to be dealt as DKA. I think that probably diabetic status may be worsened by this sepsis. Yes, probably. So this patient, I think that the better antibiotic would be meropenem. So I would, because the reason would be this patient has presented with pyelonephritis, point number 1. Okay, he presented with sepsis and septic shock. Yes. So we should not take any chance. So and most of the time the pyelonephritis is precipitated by gram-negative organisms. Okay. So mero can be very much potent against gram-negative, but what you have to remember that this not only acts against gram-negative, it can act against gram-positive also, gram-positive organism and as well as anaerobic organism also. Okay. The only few organisms only it is not able to counteract, especially among gram-positive, especially in MRSA, against methicillin resistant staphylococci and Enterococcus faecalis and Faecium. These are the organisms which are inherently resistant against meropenem. So I think that we have almost covered. So this patient presented with classical sepsis and septic shock with acute kidney injury. I think that you have to do liver function test. I think that you didn't do. I think that yes, that's sir, very, very important, because any patient that involves sepsis and septic hypotension, then you have to do each and every organ profile. So septic coagulopathy to be looked for in the form of PT, APTT, even sometimes we used to do D-dimer as well. and you look for acute kidney injury, and you look for acute hepatitis also, sepsis induced hepatitis, that's also you should look for. Then very very important is blood culture. Okay, we treat sepsis, but we fail to draw blood for blood culture, but you cleverly did procalcitonin,
Yes.
which is one of the very good biomarker for sepsis.
Sepsis.
I think that you have extensively discussed. Thanks, Sugantini. I think that you have been immensely benefited with our ward rounds. Thank you.
Thank you, sir. Thank you for your extensive and elaborative discussion, sir.
Yeah,
Okay.
thank you.
For more updates, follow JIP Academy.